welcome everyone. Today's Back to School webinar is brought to you by NephCure Kidney International and GLEAN, the Glomerular Disease Learning Network. My name is Kristen Hood and I'm NephCure's Director of Clinical Outreach. And my partner, Kelly Helm, is also here tonight with me. Kelly is the Director of Patient Engagement, and Kelly and I will be moderating today's webinar. And before I introduce to you our expert panel, I'd like to let everyone know that this webinar really is for you. We have experts here to answer questions and perhaps guide some thought and conversation around going back to school. And knowing that most of you, if not all of you, have questions on COVID-19 pandemic and how it impacts your decision on going back to school, we do have an expert infectious disease physician, Dr. Downs, who will give an overview of the pandemic to start us off. And so from there, the webinar is yours. So what I want to encourage you is to use the Q&A function in your Zoom toolbar. It's that toolbar right at the bottom of your screen, and ask questions. You can start as early as right now. And Kelly and I, throughout the session, once Dr. Downs is finished with his overview, we will open up that Q&A and we will moderate the questions from there. So please know this webinar is being recorded and it may be used as a patient resource for NephCure or GLEAN in the future. And now for our panelists. Kelly, do you want to start us off?
Sure. I'd like to introduce everyone to Dr. Michelle Denberg. Dr. Denberg is a pediatric nephrologist at the Children's Hospital of Philadelphia with advanced training in clinical epidemiology. She also serves as an associate professor of pediatrics and epidemiology at the Perelman School of Medicine at the University of Pennsylvania. Dr. Denberg's clinical and research interests include childhood kidney diseases, and she is also an investigator for multiple pediatric studies. Welcome, Dr. Denberg.
Thank you. Happy to be here.
All right. Sorry, I'm having a problem with my screen. Kelly, can you go ahead and do the second one?
I sure can. Next, I'm going to introduce everyone to Dr. Bradley Dixon. Dr. Dixon is currently the section head of nephrology and associate professor of pediatrics and medicine in the renal section of the Department of Pediatrics at the University of Colorado School of Medicine. Dr. Dixon's clinical interests focus on complement-mediated kidney diseases such as MPGN and C3 glomerulopathy, and he is also an investigator in several clinical trials of novel, that means new, different new kinds of treatments in these specific complement-mediated kidney diseases. Welcome, Dr. Dixon. Thank you for being here.
Thanks. Happy to be here. Thanks for having me.
Yeah, next up is Dr. Joseph Flynn. He is a professor of pediatrics at the University of Washington School of Medicine and chief of the Division of Nephrology at Seattle Children's Hospital. He's also the current editor-in-chief of the Journal of Pediatric Nephrology. He's held many leadership roles in many national and international organizations and is a steering committee member of GLEAN, the Glomerular Disease Learning Network. His research has focused on the treatment of childhood hypertension and cardiovascular disease in children with chronic kidney disease, and has been an active clinician seeing patients from across Washington State and Western Montana. Definitely an area of underserved needs. So thanks so much, Dr. Flynn, for being here. And great, thanks. And Dr. Downs is here. He is an attending physician in the Division of Infectious Diseases and a faculty member of the Center for Clinical Pharmacology and the Center for Pediatric Clinical Effectiveness at the Children's Hospital of Philadelphia. He's also an assistant professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. Dr. Downs' research focuses on the antibiotic use and drug toxicities in children, and his clinical focus is on the care of critically ill and immunocompromised children. Dr. Downs has been heavily involved with the development of local and national COVID guidelines, including those focused on the use of antivirals and monoclonal antibodies in children with COVID-19, and return to school guidance for pediatric solid organ transplant recipients. So we are so excited that you are here today too. Dr. Downs, thanks for being here.
Thank you for having me.
And last but not least, we have Angela Young, who is a registered licensed dietitian nutritionist. She received her undergraduate degree in human nutrition and dietetics and a dietetic internship at the Ohio State University. Also, she completed her Master's of Science in Nutrition and Dietetics from Central Michigan University. She's a certified nutrition support clinician and a professional member of the American Society of Parenteral and enteral nutrition. Sorry, Angela, I should have read this before. Angela has a focus in pediatric nephrology and dietary behavior modification, and is currently working as an outpatient dietitian in nephrology at Seattle Children's Hospital. And we are super glad to have Angela here to help us all with our dietary and nutrition questions. So thanks for being here.
Thanks, Kelly.
Yeah, diet and nutrition is always a hot topic going back to school. So thanks, Angela. So now we will turn it over to Dr. Downs. Dr. Downs, if you want to go ahead and share your screen, and we look forward to hearing what you have to say today.
Great. Well, thank you again for having me, and I appreciate the opportunity to speak on to this group about COVID-19. And we're going to talk a little bit about COVID-19 and what's happening in the United States. Obviously, it is a hot topic once again, and continues to be at the forefront of many people's minds as we make decisions about heading back to school. But specifically review it in the context of nephrotic syndrome and immunocompromised children, and hopefully provide some guidance and some ways to think about risk for your child as you head back to school this fall. So here's a figure from the Center for Disease Control about what COVID has done in the United States over the last year plus. We can see this is the incidence of COVID cases in the US by age group. And what's notable here is we all remember this huge spike that we had over the winter that was predominantly affecting older individuals. You can see the darker colors are older individuals, and they make up the majority of cases. If you shift over to the right-hand side, which is more current now in July of 2021, we see the current cases, and unfortunately starting to see an uptick in the cases across the United States. And what's notable for us in pediatrics is that the younger ages, the lighter cases, are a little bit more towards the middle now than they once were, which represents the fact that we're seeing the vaccine working in older individuals, and those that have yet to be able to receive the vaccine start to make up a higher percentage. We're fortunately far away from the numbers that we saw earlier in the year and at the end of last year, but the newer spike that we're seeing is starting to raise some concerns. And what it is that we're concerned about is the current level of transmission in the United States. So shown here are again, figures from the Center for Disease Control. This is transmission over a 7-day period. On the left-hand side is a month ago, and on the right-hand side is current. And just to give you some reference, red is bad. So as we can see, we're seeing high levels of transmission of COVID in the United States across most of the regions of the US. You'll see some blue that's scattered in there, then that likely represents a lack of reporting rather than there actually being no cases in those places. But you can see some pretty solid red throughout the South, throughout the Western United States, and it's starting to creep up towards the Northeast as well. And this is what has us concerned as we head back towards school. And a lot of this, in fact, the vast majority of these cases are due to the Delta variant and predominantly in unvaccinated individuals. So the Delta variant, which is also referred to as the B.1.617.2 variant, is a different strain of COVID. It's the same virus we've been dealing with since the beginning, but because of time and the way that viruses behave, we see small mutations that take place over time. These can be from just random mutations most of the time, and as one random mutation happens to confer a little bit of an advantage for the virus, that strain can then become a more prominent strain. And so that's what we're seeing with the Delta variant. This is now the more predominant strain in the United States and throughout the world. And this strain is a little bit more transmissible or contagious than previous variants. There's some question about whether it could be a little bit more severe, associated with more severity, but that's difficult to really tease out because we have some effects of vaccines that weren't present during previous variants, but it certainly appears to be more transmissible than previous variants that we had to deal with. And fortunately, the vaccines remain highly effective. The vast majority of cases of COVID-19 in the United States right now are among unvaccinated individuals, and more than 97% of deaths in the United States are in unvaccinated adults. And so vaccines are still our biggest tool and our biggest weapon against this virus, especially at preventing serious infections and deaths. And so even if you might hear that there are breakthrough infections and that you might hear some people that perhaps are not on the pro side of vaccines saying that the vaccines are not working, well, I can state with clarity that that is not true. The vaccines are in fact highly effective, preventing serious illness and death in this country and throughout the world, and are really our best weapon against this virus and against spread of the virus. And unfortunately, we are seeing some data, however, that because of how many people are vaccinated, when cases do occur in vaccinated individuals, that they're capable of spreading this virus. And so that's led to a little bit of shift in guidance recently. Earlier in the summer, there was guidance that if you were vaccinated, you no longer needed to wear a mask. Now the CDC has recommended that vaccinated individuals wear masks indoors as well because of how contagious this particular variant is. And so it's not, again, not because the vaccine's not working. It's not because our guidance before was incorrect. It's just that things have changed. And unfortunately, this virus is now spreading again, whereas earlier in the summer it wasn't. So I want to answer some specific questions about COVID in children and in those with nephrotic syndrome. So first question that we received are children with nephrotic syndrome at higher risk from COVID-19? Well, fortunately, all the things that the parents and families of children with nephrotic syndrome have done over the last year have been very effective at preventing COVID-19 in this population. So I will say that first and foremost, it's hard. We don't have a lot of data because you've done such a good job at preventing this infection. But we know that compared to adults, children and adolescents are at low risk for hospitalization and severe disease with COVID-19. But those with impaired immune systems can still get severe illness. So we're still treading lightly with this virus in children, particularly those that have compromised immune systems. But there are limited data regarding COVID-19 risk in immunocompromised children overall. When we look at the body of literature that we've developed in the last 16 to 18 months, we believe those that are at highest risk for severe COVID-19 among children are those who are receiving high intensity chemotherapy, kids who have just been diagnosed with cancer and started on chemotherapy, those who have profound antibody deficiencies or dysfunctions, so where their antibodies either they can't make them or they're not made, or those who are taking medications that suppress their ability to make antibodies or who have low lymphocyte counts, which are the cells that make antibodies. Those are the patients that we think are at highest risk. So it's not all children, and it's not even all immunocompromised children. Among the data that is out there about children with nephrotic syndrome is relatively limited, again, because there have not been a lot of cases in this population. But in a study of 159 children and young adults who received B-cell depleting therapies, which is rituximab predominantly, a medication used commonly in this population, there were no cases of COVID-19 during the COVID-19 peak in Italy last year. And this included 6 household contact members who had COVID-19. They did not spread it to those children that were receiving those therapies. There are only rare reports of COVID-19 in the nephrotic syndrome population, and it can cause relapses of nephrotic syndrome when those infections have happened, but most cases have been relatively mild. There have been very few reports of severe disease in this population. So overall, we don't think that children with nephrotic syndrome appear to be at higher risk of contracting COVID-19 or developing severe COVID-19 unless they have other comorbidities or are taking significant amounts of immunosuppressive medications. So the question then that also gets asked is it safe for my child to receive COVID-19 vaccines? Well, currently there are 3 vaccines that are authorized for use in the United States overall. There's the Pfizer BioNTech vaccine, that's an mRNA vaccine. That's authorized in people who are 12 years of age and older. There's the Moderna vaccine, which is a similar vaccine to the Pfizer vaccine. It's also an mRNA vaccine that's authorized in individuals 18 and older. And then a J&J vaccine, Johnson & Johnson or Janssen, that's a viral vector vaccine authorized for use in people 18 and older. Currently, the only one that we are able to give because of age to children is the Pfizer vaccine. And the mRNA vaccines are currently a 2-dose series, while the J&J vaccine is a single dose. And it's important to remember that these two vaccines are not interchangeable. So is it safe to give these vaccines? It absolutely is safe, but I wanted to address one condition that has come up very frequently recently, because this has gotten a lot of attention in the news. And it's a very rare side effect called myocarditis, which is inflammation of the heart muscle. It's been reported a little bit more often in patients who have received the mRNA vaccines compared to placebo. And so this raised the attention of the CDC and the FDA, who reviewed this, as well as the World Health Organization, and has reviewed this in detail. Most often, the inflammation that occurs is very mild, and it's occurring in the first few days after the second dose of an mRNA vaccine. It's much more common in adolescent young adult men than it is in females or older individuals. Again, it's typically mild and it self-resolves, but this is an important complication to be aware of. It tends to present with some chest pain. But to give you a sense of how rare this is, the complication occurs in about 1 in 25,000 second doses of vaccine in individuals that specific age 12 to 29. So it is a very rare but important side effect to be aware of. But to put that in the context of vaccination overall, per million doses of vaccine in this same age group, which we think is at lower risk of severe infections and adverse outcomes, these same vaccines will prevent 11,000 cases of COVID, more than 560 hospitalizations, 138 ICU admissions, and 6 deaths. So the benefits of vaccination far outweigh these risks of myocarditis, which is the most notable side effect that's been reported so far. Outside of myocarditis, the data on safety of these vaccines is tremendous. There's been millions of doses of these vaccines. They've been highly effective and very safe. One question that does come up about individuals with nephrotic syndrome as well as other autoimmune conditions is whether vaccination itself can trigger a relapse. And the data on the safety of COVID vaccines in children with nephrotic syndrome is still being gathered. There's not a lot of reports about vaccination specifically in that population, but from other vaccines that are used in children with nephrotic syndrome, we've not seen that relapses occur because of vaccinations. And while there are reports of COVID-19 illness itself triggering nephrotic syndrome, there are really no clear reports of COVID vaccination triggering that relapse. And so vaccination is encouraged in this population. The other question that is related to this is, are COVID-19 vaccines effective in this population, in children with nephrotic syndrome or any children who are taking immunosuppressive medications? So this is a slide that I just want to show to give you some context, because there is information that is out there about the decreased effectiveness of vaccines in transplant recipients. This is data from a journal called Transplantation about adult kidney transplant recipients who received 2 doses of the Pfizer vaccine. And what's shown here are the percentage of patients who develop antibodies to these vaccines. So there's been a number of studies like this that have shown that transplant recipients have fewer antibodies to COVID-19 vaccines than other individuals. In this study, the comparator group was adults who are on dialysis waiting for transplant. And in those patients who have end-stage renal disease, the vast majority developed antibodies, so 87%, whereas far fewer patients that were kidney transplants had antibodies. But antibodies don't tell the whole story about vaccine effectiveness. So in Israel, 2 doses of mRNA vaccine was effective against infection in 90% of individuals. and 71% of individuals who were receiving immunosuppressive medications were also protected against infection. So much different numbers than you see when you only report antibodies. And in fact, the vaccines were effective against symptomatic infection in 94% of all individuals and 75% of immunosuppressed adults. And the reason that this is also important is that in each study that's been looked at that examines antibody responses to these vaccines, antibody responses are much higher in younger patients than they are in older patients. And so we have every reason to believe that vaccines are more effective in younger patients and younger immunosuppressed patients than they are in older immunosuppressed patients. And so it's difficult for us to really extrapolate the experience in older transplant patients to younger ones, and similarly to older immunocompromised patients. So we think that in all likelihood, these vaccines, if and when they become available to children, will be very effective even in our immunocompromised patients. And if we remember back, we've been a little bit of a victim of our own success here, in that the threshold that we had when these vaccines were being developed for effectiveness was 50%. And so when we saw that these vaccines were 90% effective, everyone was extremely excited. And so when we see some numbers that dip down into the 80s or 70%, people will claim that they're not effective, but these are actually remarkably effective vaccines, given what we were hoping that they would do, and what some other vaccines like we have experience with in terms of, at times the influenza vaccine in immunocompromised patients, the effectiveness of that is not 100% either. So we're very encouraged by these numbers. And I think while people might draw attention to some lower numbers than initially reported, these are still extremely effective vaccines. Rituximab, as I mentioned before, is a medication that affects the cells that make antibodies, and it's a common medication in children who have nephrotic syndrome. And a question that comes up often is about the optimal timing of any vaccination when someone's on rituximab. If your body can't mount an immune response, can't make those antibodies, is that the right time to give vaccine? We don't have a lot of data in children, but among 83 fully vaccinated adults with rheumatologic disease, antibody responses were decreased in those who'd received rituximab, but not other immunosuppressive therapies. So you can see the numbers here, about 43% had mounted antibody response. And I think that that's relatively expected with this specific medication. But compared to all of the other immunosuppressive medications that are given in that population, which include many medications that are used in children with nephrotic syndrome as well, the antibody responses was quite robust. So we do think this is a specific effect of rituximab. And so the recommendation currently is that when possible, it's encouraged to wait 4 weeks after vaccination before starting rituximab. So if your child's not already receiving that medication, the goal would be to vaccinate first and then start that agent. If your child's already receiving rituximab, the recommendation would be to try to administer COVID vaccines, if possible, about 12 weeks after the rituximab. If we're, unfortunately, we're in the current, spike of Delta that's going up, it's better to give the vaccine, which may not be optimally effective, than to not give the vaccine at all. So again, it's something to discuss with your nephrologist about the optimal timing of that specific medication. And there's no safety concerns. It's just whether or not the vaccine is going to be effective. And so currently, as I mentioned, COVID vaccination is recommended for all patients who are eligible for it, 12 years and older. We hope that this fall that's going to include children of younger ages. Those studies are ongoing, and we certainly hope will allow for approval in younger school-age children as well. But discuss the timing of vaccination with your doctor if your child's on immunosuppressive medications. Along these lines, a question that's being asked is, will a child need a vaccine booster, or will anyone need a vaccine booster? Currently, there's no recommendations for vaccine boosters, although I know there are some countries that are giving them. I don't think that is really based on specific data as much as it is fear of cases of COVID. This was a study that was performed that tried to look at the risk of when antibody immune responses would wane based on what we know in terms of vaccine effectiveness. And so on the left-hand side, what's showing here in the solid bars are when you might have a dip in efficacy against mild disease, and these dotted lines are against more severe infection based on how effective the vaccine is. And the vaccines are somewhere between 90 and 95% effective. And you can see that really booster doses would not be needed to prevent severe infection for more than a year based on these modeling studies, where it would drop down below 85% or so. And if we're talking 95%, even farther out than that. And that's because these vaccines, they do a better job protecting against severe disease than they do against mild infections. So currently, we don't want to make our decisions based on antibody responses alone. We expect that antibodies will decrease in a vaccinated individual over time. So when you hear reports of vaccinated individuals having waning antibodies, this is expected. The vaccine effectiveness is still very good at 6 months, even in the face of Delta. And so we're very encouraged by this. So currently no recommendations for boosting outside of a clinical trial. Lastly, I want to spend a few minutes talking about whether we should be taking any special precautions for children this fall. So the standard things that we've been doing for the last year and a half are working very well. Hand washing, as we always recommend to prevent any type of infection, maintaining a safe distance when possible of 6 feet, wearing masks, cleaning surfaces that have been soiled. These are important things that we're doing routinely, and this is working. This has been working. It got us through the winter in these huge spikes. It will get us through this fall. And these recommendations is in part what has led to the American Academy of Pediatrics and the Center for Disease Control recommending mask use for all individuals returning to school, for both school-age children and staff. And we fully endorse that recommendation. But we know that there's going to be some variability from school to school. Despite these recommendations, not all schools are going to be requiring the same thing. And so will it be safe for children to return to school? Yes, it will be, but we want to do as much as we can to keep children safe. And there's going to be variability in what schools are willing to do. We know that we want to prioritize in-person school as we've dealt with the last year. Remote schooling, which has been very effective for some, has not been effective for many. And so we want to encourage in-person schooling when possible. And as I just mentioned, universal masking is recommended for all children. If you have a child that's going back to school and you're still uncomfortable or have questions, you need to individualize those decisions for your child and your family. And so how do you make decisions? What types of things do we want to look at in terms of risk for individuals? We can break them down into a few different categories. So one has to do with your child or the patient, as we say, when we're dealing or considering immunocompromising conditions. So we can break it down into higher risk scenarios, moderate risk scenarios, and lower risk. None of these mean yes or no in absolute in terms of going to school, don't go to school, wearing, what to do. These are just how to sort of say, where does my child fall in terms of risk? If they're on high levels of immunosuppression, that carries higher risk than if they're on no immunosuppression or low levels. Comorbidities are a big contributor. So not just immunocompromise and immunosuppressing medications, but obesity, diabetes, chronic lung disease, these continue to be higher risk conditions for children and for older individuals as well. We can also think about what's going on in the community when we think about risk to our children. So in places where viral transmission is high, that's a higher risk scenario. Again, that doesn't mean you can't go back to school, but that means that we need to be a little bit more cautious in terms of wearing masks and encouraging our children to wear masks if other children aren't wearing them. The vaccine rates in the community are helpful to know because even if there are many cases among vaccinated individuals, they're less likely to be spread from one individual to another. We also want to know if contact tracing is occurring because this is really going to continue to be an important measure for us to make sure that our children aren't around other kids with COVID-19. As we saw this summer and we're currently experiencing, as everyone has taken their masks off this summer, we've seen all those viruses that we avoided last year coming back. And that includes influenza, RSV and other viruses. And so we want to make sure that we know when COVID is causing the sniffles versus another type of virus. And so some schools may be doing symptom screening. We hope that they will be to try and prevent infections from coming into the school. And then lastly, the pieces that we can all do and ask our schools to be doing in terms of asking them to require masks for all students and staff. We want to still encourage social distancing. I know that that's not always possible when all children are returning to school. We hope that if your child needs special accommodations, that they'd be willing to allow for larger distance between he or she and another student. We'd also like them to try to limit the amount of mixing that's going on between the students. The more commingling that's occurring, the more opportunities for spreading infection. And ventilation's been, a question. I think, we'd like to see all schools have good ventilation. That's not always financially possible. And so with that, I want to close just by saying there's still a lot that we don't know about this virus. I know that seems frustrating this far into the pandemic, but what we've done to prevent infections has really been instrumental at keeping children safe. And on the flip side of that, it's prevented us from knowing how does this virus affect many kids because we've been able to keep them COVID-free. We do want to encourage vaccines in all who are eligible and continue to be vigilant, take precautions, and work with your physicians to individualize your medical decisions.
Thank you so much, Dr. Downs. That was a great presentation to get us started on today. We do have several questions coming in. And Kelly, do you want to get us started on some of those questions? At this time, if anyone is here, and I know that there's quite a few of you, this would be a great time to go ahead and put your question into the Q&A section if you haven't already done so.
Right, so we'll get started with a question about prednisone, because probably lots of your kiddos are taking prednisone or other immunosuppressants. Are children on prednisone at higher risk of COVID? Is there any data on this? Can a child on prednisone receive a vaccine if the vaccine is approved for their age group?
So I'll answer that second question first. I would definitely encourage a child on prednisone to receive a vaccine. That should be a medication that would allow the vaccine to be effective. And so I would certainly encourage that. In terms of data, there are data. It does not appear that children who are taking steroids as monotherapy would be at higher risk of COVID or severe COVID. But if they're receiving extremely high doses, like pulse dose steroids, in that very short interval, there will be a slightly higher risk during that. But if your child's taking steroids and other medications, then you need to discuss with your doctor about how those drugs might interact to affect the immune system.
Yeah, definitely. For our nephrologists here on the panel, high dose steroids are quite common, even in, the youngest of patients. And so do you have a concern? Do you agree with Dr. Downs as far as the high dose steroids and, being more, susceptible to COVID? Have you seen this or experienced this in any of your populations? Open to anyone.
And I guess I'll jump in first by saying that setting aside the COVID vaccine being a novel way that we vaccinate children, we are quite aggressive about getting the influenza vaccine to our patients every fall who have nephrotic syndrome, whether or not they're on prednisone for treatment. The effectiveness may be diminished somewhat by prednisone, but no that doesn't hamper us from administering that vaccine. So I think I draw a page from that experience in with the COVID vaccine. So very much in line with what Dr. Downs shared.
So along those lines, talking about vaccines, obviously currently the 12 years old is the youngest age right now able to get a COVID vaccine. Those of you in nephrology practice, when it's open to children younger than 12, will you be encouraging your patient to get the vaccine, or is this something that is individualized based on their care plan? How would you discuss this to our audience this evening? Dr. Denberg, do you want to start?
Sure. I think I would take the same approach when the vaccine is available to children under 12. I would take the same approach as now, which is, we are consistent with what Dr. Downs presented. We are recommending the vaccine to all of our eligible patients. And I think really the only element of nuance has been with rituximab, potentially timing of the vaccine to make it optimally effective. But that's nuanced and individualized, because sometimes there's more benefit to giving the rituximab, if the patient's actively nephrotic, versus you have some degree of ability to wait but in total 6 weeks, so between the doses of the vaccine and then additional 4 weeks before giving the rituximab. So it has to be tailored to the individual patient. And I think the rituximab, because it does seem to have more of an effect on the how the vaccine works, there may be some timing issues, but we are recommending it for all eligible patients, and it will be the same when it is available to our younger patients.
Yeah, absolutely. Thank you for that. All right. There's another question here, and I'm just going to open this up to any of our physician panelists. One person is asking, should they try to boost the immunity of their daughter who's going back to school? I know that this is a common question that I've seen in some of the private social media groups, as far as herbal, boosting, echinacea, some of those others that you might be common with. So how would you respond to this? Dr. Flynn, I'll let you go first.
Oh, great. I guess I would say that, I always worry about harmful effects of some of those supplements, because we don't know what they contain. And it's very difficult sometimes to really parse out the ingredients of some of these herbal products, and there may be unknown constituents in the way it's formulated. There could be a drug interaction of some herb with one of the patient's medications, and it's very hard to find information about that part, let alone any information about whether that works. So my answer is always, well, show me what's in it, and show me that what is in it is, I can, look up, and then we can talk about it.
Yeah, that's actually probably the best thing to do, and to, definitely let your physician know all the medications, including over-the-counter or herbal type of remedies. And I think sometimes whenever you think about it, if you are thinking about boosting the immune system, sometimes what we're doing to control nephrotic syndrome and some of the diseases causing nephrotic syndrome is that we are reducing the immune system. Dr. Denberg, do you have anything you'd like to add?
Yeah, no, I completely agree with Dr. Flynn, and I actually, I really encourage all my patients, I specifically ask about supplements, over-the-counter medications, and we have I usually go to, if I have not heard of it or I don't know the contents, go to our pharmacist who, is specialized in nephrology and has resources to look up safety, general safety, and then interactions with drugs that they are taking for their nephrotic syndrome or other kidney condition. And I think it's just really important because there may be interactions, as Dr. Flynn mentioned, or just kidney related side effects. So I think, leveraging resources like pharmacists who do have the means to investigate contents is really helpful.
All right, so our next question talks a little bit more specifically about medications. Actually says, we know rituximab depletes B cells and patients taking rituximab are at a higher risk of COVID-19. Does tacrolimus deplete B cells too? What is the prognosis for children taking tacrolimus? So to our nephrologist, could you maybe touch on calcineurin inhibitors and a couple of other meds that are typical, like maybe CellCept, and talk a little bit about the difference between those?
Maybe I can start, and Michelle, you can jump in. Tacrolimus and CellCept work differently than rituximab in that they're not depleting medications. They don't make your lymphocytes, which are the cells, they're lymphocytes that are effective in viral infections and lymphocytes that make antibodies, the B cells. And tacrolimus and CellCept can alter the way B cells and T cells talk with one another, but they don't kill those cells like and deplete them like rituximab does. At least in my estimation, since they're not depleting and they don't cause a depletion of antibodies, that they would be of lower risk for severe disease than more intense immunosuppression.
Yeah, and I think we have a lot of experience both for nephrotic syndrome, but also in our solid organ transplant recipients, so kidney transplant recipients and other other heart and liver transplant recipients with those medications and combinations of those medicines, so tacrolimus and CellCept. So I think, specifically in terms of degree of immunosuppression, if when we're thinking about COVID in particular, we can, I think, extrapolate a lot from the transplant population, which is where we have most of the data right now, as Dr. Downs had presented.
Great. And just to piggyback off that previous question, is there an increased risk of COVID-19 for children who have taken a course of cyclophosphamide in the past? In this patient parent's case, it was 2 years ago.
I think that by 2 years, probably not. We don't use it very much anymore. I probably have used as much as Brad and Michelle put together because I'm old. Like rituximab, it's given to deplete B cells, although it's not given in the same kind of dosing regimens that are considered depleting. I think if the child had it 2 years ago, I wouldn't worry at this point.
Yeah, I agree. And I think another point to consider in this is that the risk is not specific necessarily to the medication itself, but also the amount of medication that someone's receiving. So there are gradations in terms of how much immunosuppression someone can be on, even with the same drug. So like Dr. Flynn mentioned and Dr. Denberg, Dr. Dixon, there's a combination of, your doctor can help you sort through just how how much immune suppression your child's receiving and what that risk is. But I think in general, most of these agents have not carried an increased risk for children.
And Dr. Downs, we actually have another question kind of regarding, you'd mentioned high levels of immunosuppressives. Cassie asks, can you define high levels? So are we talking like if patients are like transplant patients are on multiple immunosuppressants, what are concerning levels, or just levels that maybe parents should be a little more vigilant?
Yeah, so that's a really good question. One way to put that in context, as you mentioned, are transplant recipients. So in the first 6 months after a transplant, those patients receive very high levels of immunosuppression to try to prevent rejection. So that includes medications that really knock down those lymphocytes and the lymphocyte function. And it's really in those first few months after transplant, they're receiving multiple medications. They've received what we call induction therapy. After that, patients tend to be on stable immunosuppression that carries much lower risk. But one very crude measure that we can look at that I alluded to earlier is the total number of lymphocytes that someone has. When your doctors are routinely measuring complete blood counts, they get that information back. And so if someone's on multiple agents, sometimes we can see those effects on those cells.
Thank you. There's a question here from Riva. She's asking about what tips do you have for sending kids back to school safely besides wearing a mask? I know, Dr. Downs, you kind of covered a list of things that we've been doing for the last year and a half that have actually been working. I'm gonna go ahead and ask that again, if you don't mind, going over that list again. But I'm also going to ask another question. If there is a certain type of mask that is preferred for our children to wear, and if you have any thoughts on that as well.
Yeah, so the preferred mask is the one that your child's going to keep on his or her face. But if we had to pick a mask in terms of the most effective one, the surgical masks that you see there are 3 different layers of synthetic material that you can purchase online. Those ones, the reason that they're most effective is the 3 layers, what it's basically doing is forming like a net, and that prevents both particles from going out and particles from going in. The cloth ones that are often comfortable are just a single piece of cloth and don't provide that same sort of netting that we want to see. So if you see a 3-ply type of mask, that can be of any material. That's really the reason that we prefer what's called a 3-ply mask. In terms of other steps for getting back to school, there's the optimal scenario in terms of what we really like to see for all high-risk children, and then what we can ask schools to do. And so I think in addition to encouraging your children, is trying to work with the school. If you have a child that's at higher risk of severe illness, and it doesn't have to be from COVID, it can be from flu or anything else, is to try and have an open line of dialogue with your school so that you can know when other children in the classroom might be sick. Having an IEP or another educational plan in place so that you can access distance learning or remote learning for short periods of time if you're concerned about the risk to your child. I know that we're encouraging in-person school, but I do worry this fall with all the other viruses that we're going to see. If schools go back with no masks on, it's going to be very difficult for them to stay open because there's going to be sick kids, many of which are not going to have COVID, but it's going to be hard to know. And so having a plan in place to be able to transition to remote learning would be an effective strategy. And then, I think that those are the big things that we can do. The social distancing part is going to be hard. It's going to be difficult in classrooms that are filled with students to really maintain that 6-foot distance. But having a good relationship with your child's teacher to try and encourage situations that may be higher risk, to provide some accommodations. Perhaps that means your child leaves the classroom to go to the next classroom before all the other children go into the hallway. Maybe that means there's different accommodations in terms of gym class where everyone's huffing and puffing on each other, or lunchtime or things like that.
No, that's a great point. And it's important in our poll that we had open at the beginning of our session. One of the questions was, do you have a 504 plan or an IEP set up? And ironically, I want to say 67% said no, they need more information. So the things that Dr. Downs was just mentioning around accommodations, this would definitely be something you would want to talk to your school about whenever you're trying to get a 504 in place. I would say that any of you that have children with nephrotic syndrome or any of the disease causing nephrotic syndrome, you are eligible to get your child a 504 plan. IEP is a little bit different. NephCure has a great website that actually specifies the difference between 504 and IEP. And I think Kelly's going to post that link in the chat for those of you who need more information on the difference, and actually we actually have some great resources to help you set that up in your school. Most of the time, you will go to your school counselor or even maybe one of the administrators, the principal, assistant principal, and definitely your child's teacher. There are forms that you fill out and that the physician would fill out. So your nephrologist who is managing the care of your kidney kid would be the one that you would most likely want to go to for that. Definitely, if your child also has other comorbidities, you would want to include any other specialists that you have as well. So that's definitely important. So, you know, including the 6 foot distance, if you're able to. Sometimes that is hard to do. However, Dr. Downs made a good point of, you know, what about those transition periods? Maybe your nephrotic syndrome child would be able to leave class, you know, 2 minutes before the bell rings. I know I have my nephrotic syndrome child is in middle school and the halls get busy. So definitely asking him to leave a couple minutes early before the crowd really hits would definitely be a great tactic. And then again, at the end of the day, when that last bell rings and everyone floods the halls to get out into the bus or to the carpool line, those would also be other accommodations that you may want to ask for. These are not uncommon accommodations that schools get, especially when you consider other situations, such as someone who's on crutches who might have a broken leg, you know, that sort of thing. They leave class a little bit early to get to the next class. So just including your child in those types of situations would be a good thing. Any of our nephrologists or Dr. Downs, do you have anything else to say around these types of accommodations?
No, I would just echo that. I think it's really helpful to have your nephrologist and potentially social worker in the division, you know, communicate in open communication with the school and really develop customized ways to maximize safety. So I think, you know, thinking about hallways, bathroom breaks, lunchtime setups, and I think just having that 504 in place can really facilitate those arrangements.
Yeah, and you know, just to tag on, and then we're going to move on. I think Kelly's got a good question for you. Is that, you know, whenever you're thinking about a 504 and you're thinking about those accommodations, think about those common things that we have been doing for the last year and a half that have been able to protect our children, such as frequent hand washing, the use of hand sanitizer. So look at your child's classroom, look at your school environment. How accessible are those things? Will they allow your child to carry his or her own hand sanitizer? If you're in an elementary or a pre-K setting, you know, how often are they washing hands? I used to work as a school nurse, and so I know that whenever I would have those children with those high contact peanut allergies and that sort of thing, you know, I would go into the classrooms and I would teach kids, hey, if you have a peanut butter sandwich today, you know, John over here is allergic. So after you eat, you want to make sure you wash your hands before you go back to classroom. You know, how about those high contact things? Are they using cubbies with, you know, everyone just puts their crayons in a cubby in the middle of the table and they're all using? Does your child need their own set of art supplies if they're in middle school or high school, if they're not using shared supplies? So think of those classroom dynamics. Think of what we've been doing that has been working and how can you transpose that into the school situation. So A 504, if you do not have one, I would encourage you to reach out to your school as soon as possible. I know many schools, administrators and counselors are already back getting prepared for the new school year. So I would definitely reach out and get that started for your nephrotic syndrome kid. Kelly, go ahead.
Yeah, I'll just touch on that. A couple of people have asked about masks, and I don't know that they'll be mandated where we live. We go back to school in 2 weeks, and I have a 15-year-old daughter who I can guarantee you, if she's the only kid wearing a mask, is not going to keep that mask on as a sophomore in high school. So me being able to put that as an accommodation in her 504 plan gives the teacher the power to remind her frequently to put her mask on and keep it on. So things like that. I think we really just have to work around what our local mandates say to do the best to protect our children, and then also balance that with their mental health and the need academically to be in class. One thing I wanted to ask Angela, actually, it's something that came to my mind last year as my son was back in school when he wasn't quarantined, obviously, but something that came up was hot lunches. And I wanted to get your opinion on if you think it's safer. Obviously, my son doesn't have kidney disease and is not on a low sodium diet. So I mean, most school lunches are not super low sodium, but how do you feel about bringing food from home versus eating food at school? Is there a risk there? Is it fairly safe? What are your thoughts?
Yeah, that's a great question, Kelly. I think that the schools will probably be doing everything they can to keep school lunches as safe as they can. But I think the only way that you can go about being 99% safe is bringing your kids lunch from home. And ultimately, like Kelly was saying, that's a good way to keep their lunch lower in sodium as well. And maybe to also put like a hand wipe in there with their lunch so that they can, wash their hands or at least wipe down their hands before they start to eat.
And a threatening note, wash your hands before you touch.
Right. As a general rule of thumb, we get this question a lot too at NephCure. As far as a child with nephrotic syndrome who is in remission, whether it be medicated remission or just has gone through the prednisone or whatever, and they're in remission. Should they limit sodium in remission? And as a caveat, if they are in a relapse or if they are spilling protein, what's a general rule of thumb? What's that range of sodium that you suggest children stay in? And I'll just open that up to Dr. Denberg. Do you want to answer?
I think, I think it's a balance of, it's most important to be on a age appropriate sodium restriction when actively nephrotic, because it really does help reduce swelling. I think in general, a less than 2 gram sodium diet is a healthier diet for everybody. So we know that it helps also control blood pressure. I think we often talk about that it's easier for the child if the family is joining in the lower sodium diet. So, it does help that if it's something that can be maintained when the child is in remission as well, especially if relapses are a frequent occurrence, or if the patient is steroid resistant, or spending a lot of time in relapses. That being said, some leeway, especially when in remission, I think is also can be helpful from a mental health standpoint as well. So I think it's a balance. I mean, certainly more important when in relapse, but for everybody, less than 2 grams a day of sodium is generally recommended. And I would ask Angie to weigh in, and Dr. Flynn, who's also a blood pressure expert.
Yeah, so the only thing I add to that is to be strict with the sodium, lower sodium diet when they're getting a lot of steroid.
Yes.
Because that'll, contribute to higher blood pressure. And then I tell them to talk to Angie about how much. And, we're lucky that the dietitians meet all of these children at the time of their initial diagnosis, and they're available to provide follow-up counseling to families as things change.
Yeah,
Yeah,
Angela, go ahead.
Yeah, I would agree with what both of you said. With our kiddos, we really try to aim for like less than 1,000 to 1,200 milligrams, especially when kiddos relapse. And I find that with kiddos, when they're not kind of in that relapse time frame, trying to aim for like 1,500 to 2,000 milligrams, just because we find it's easier to transition back to that really low end of sodium requirement when they do relapse. So I feel like we find the best success when they continue to when kiddos continue to kind of follow this lower sodium diet when they're not relapsing.
So to piggyback on sodium, what about water intake? So I know that when my son is back on prednisone, right, he's also on a kind of a water restriction. However, sometimes, they still can go to school, right? Whenever they do feel good, we do send them to school, even though they might be on prednisone or some of these other medications. Is there, Angela, what do you say about water intake, especially when you're thinking about the older ones who are in athletics, whenever you're thinking about middle school and high school, and they're in a bit more intensive sports?
Yeah, I would say it's very personalized. So it's very individualized with, if they're in sports or not. If they're in sports, we might, go a little bit over their maintenance fluids. But I'm normally trying to stick with about maintenance fluids with most of my kiddos, I would say.
Yeah, that's good to know. What are some good like go-to snacks, Angela? Like if you were to give me like your top 5 snacks for, honestly, the age range K through 12, like what would you say would be a great thing to pack in a bag, whether we're talking about a kid on prednisone who wants to eat everything in their fingernails, or, or someone more on a regular diet. What would you be your 5 go-to snacks?
That's it's hard to narrow that down to 5. So I would say fruits and veggies paired with some type of protein. So, I don't know, one of my go-tos is apple and peanut butter, because ultimately that protein is gonna keep us fuller. So when these kiddos are really hungry, we need something to keep them full. So that protein is gonna be there, and that fiber is going to be there from the fruit or the veggie. So I would say pairing like a fruit or vegetable with a protein. I would say you could do some type of dairy, so like yogurt with some fruit and granola. So I think a good go-to is Greek yogurt, because you've got some protein with that, with some fruit and granola. And then, a third one, like peanut butter and jelly sandwich and a cheese stick. Every kiddo loves peanut butter and jelly. And then with your cheese stick, you're going to be getting some of that calcium. That's so important when kiddos are on prednisone, ensuring that they're getting enough calcium and vitamin D. That would be another good go-to one.
Yeah, maybe some good wholesome food. I like to say, if it grows from the ground or it has a mother, it's probably a good whole food nutrition idea. So I would probably, just to tag along, probably anything in a package is going to have higher sodium content. And there are some good peanut butter options out there that have lower sodium, or even making your own. So that's also a great option. Thanks for that. I think we have time, Kelly, for maybe like 2 more questions. Do you have any from our Q&A that you think would be good for us to answer? We'll do 2 more questions and then we'll wrap it up for today.
I do. It goes back to vaccinations. This is a really good one from one of our parents. What is the recommended timing of COVID vaccination when a patient is in relapse, or for those patients who are never in remission? What are your thoughts about vaccines there? And then also, I think we kind of answered this earlier, but if someone is weaning from prednisone, is it better to wait until they're weaned, or being that COVID is so contagious, is it better just to go ahead and get vaccinated?
I can speak to, I have really only tailored the approach to rituximab in terms of if you have some ability to wait to give the rituximab, and to wait for full immunity, but otherwise I have just recommended getting the vaccine when eligible and not based on current steroid dosage. I don't know if Brad or Joseph, you've had any other recommendations, or Dr. Downs, from other patient populations?
Yeah, as soon as they turn 12 years old. And I think as was said earlier, we don't know whether the titer of antibody is going to be the same, but you're probably going to get some response, and it will provide some degree of protection. So I think it's not a live virus vaccine. There's no reason to worry about that aspect, which of course is important when you're talking about like the chickenpox vaccine, for example. So we've just been telling families to get it done when they can.
If I could also just, and I think it was brought up a little bit earlier, but just make a plug to be up to date on other vaccines that are, especially if not live viral vaccines. So pneumococcal vaccination and influenza. So when you're seeing your pediatricians or your nephrologist, just checking in about other vaccines as well.
Yeah, and to reiterate both of those messages, I fully agree. It's really important to get all the vaccines, but also, even though we've been using this in children that are 12 and older, we have not seen any safety signals to suggest concerns about giving these vaccines in any immunocompromised group. So we know that if you don't give the vaccine, it's not going to work. Try to vaccinate at the earliest possible opportunity.
I just have one more comment / would love for everyone just to kind of wrap this up with your suggestions. But it sounds like as a whole, we heard from Dr. Downs and the nephrologist regarding the risk of COVID in general for our children, even those with nephrotic syndrome, if I heard correctly, is relatively low. And the major recommendation is that these kids should be in school, vaccinated if they can be, take precautions when you can. Is there anything that you want to leave our parents with this evening, just to give them a little bit of comfort going into these big decisions?
Yeah, I'd be happy to. I mean, so the good news is that despite the fact that we're seeing a surge in cases, children have continued to do very well. Even, we want to avoid cases in children. There are concerns we don't want to see anyone getting sick from COVID, but kids have done well, and are fortunate in that they have a little bit of benefit over those of us that are a little bit older. So, you don't want to be overly alarmed by some of the reports that are out there about some breakthrough infections and things like that. We're still seeing most kids do extremely well, but it's important to continue to be cautious because what we've done so far has worked to keep kids safe.
Yeah, Dr. Flynn, do you have any final comments?
Well, no, one thing that hasn't really come up much in our discussion today is the influence that you can have on people around you. In other words, you can be an advocate for your child and for children of other children with kidney diseases by encouraging your friends, your family, the teachers at your child's school to get vaccinated. And I think that, they tried the lottery approach and it didn't really get more people to sign up. And I think that what's really been helpful has been personal stories. And we've, all of you who are participating, you have a powerful personal story, and you can, and I hope you do use that to be an advocate, because it'll help other kids too.
That's absolutely true. Thank you, Dr. Flynn. Dr. Dixon, any final comments?
No, I would maybe add to what Kevin, what Dr. Downs shared earlier is we have time on our side in that we have had a year and a half of this pandemic to learn more about how this virus affects children, even children with compromised immune system. So I think we're armed with that information that we don't have to be quite as uncertain or scared as we were in the very beginning.
Absolutely. And Dr. Denberg, I'll let you.
Yeah, I was going to say the same thing, that, we are in a different position now than we were sort of looking to go back to school last year. And I think these are always complex decisions that have to be personalized for the child and family, but we do know a lot more than we did before. And I think, just being able to, I think in nephrology and in pediatrics, we're a very collaborative community, and just, sharing information and staying up to date and just having an ongoing dialogue, within communities like this, and, with between your family and your nephrologist, because things do change, but I think we do know a lot more than we did a year ago.
Absolutely. Absolutely. I just want to thank everyone for being here from literally all over the country. I think we've spanned the majority of the area in our country. So thank you for being here today. We have had a lot of questions that you might want to consider moving forward as you are planning your child's school year. When this webinar is over, you will find that there is a survey at the end of this. So whenever you click that you're leaving the webinar, you're going to come to a survey page. Everyone that actually fills that out today, you will actually get a very exclusive diet and nutrition guide from NephCure. It's not on our website. You can't find it anywhere on the web. We actually are only send it out on these special occasions.
It's actually not available yet. It's coming soon.
Oh yeah, so it's extremely exclusive, but it's a great one, and so we would love to be able to send that to you for taking our survey. We really appreciate your time. Thank you to all of our panelists. We have had an amazing conversation. I hope that this has been helpful to everyone, and have a wonderful evening and a great school year. I know that we will, everyone will do our best to keep our children safe at school. Thanks so much, everyone.